Welcome back, everyone. We are diving right into part 33 of our 100-part CPC exam series. Before we tear into the complexities of the digestive system, make sure to like, share, and subscribe to Decode Healthcare with Harshal. So, are you ready to absolutely master digestive coding and dodge those notorious CPC exam traps? Look, medical coding requires a super systematic way of thinking, right? The exam loves to test your attention to detail. Today, we're tackling the major coding traps hidden throughout the digestive system guidelines for 2026.
Let's jump straight into Section 1, Introduction to Digestive Coding.
Okay, the sheer size of this section in the CPT manual can definitely feel a little overwhelming. But don't worry, we're going to use a drilled-down approach to make it totally manageable. The scope of CPT codes 4490 to 4999 is massive. Think of it as an anatomical journey. We start way up at the mouth and tongue, move down to the esophagus and stomach, into the intestines and rectum. We also pick up the liver and pancreas along the way before wrapping the whole thing up with abdominal wall hernias. Navigating these codes accurately, it's absolutely crucial for your 2026 CPC exam success.
Moving right along to Section 2, Upper GI Endoscopy Rules.
All right, this is where we hit our very first major bundling trap. Notice the strict rule separating a diagnostic EGD from a therapeutic EGD. Anatomically speaking, we're talking about visualizing past the diaphragm, down into the esophagus, stomach, and the second or third portion of the duodenum. But here is the trap you gotta watch out for. A diagnostic EGD is literally always bundled into a therapeutic EGD. So if a doc goes in just to take a look, but then decides, hey, I need to do a biopsy or a snare excision or a dilation during that exact same session, you never code both. No way. You only report the surgical or therapeutic code.
Next up, Section 3, Colonoscopy and Modifier Tactics. Now, as we head down to lower GI procedures, understanding the extent of the scope is your absolute best friend for accurate coding. Look at the anatomical differences here. A flexible sigmoidoscopy only goes up to the splenic flexure, but to report a true colonoscopy, the documentation has to explicitly show that the scope reached the cecum or the ileocecal valve.
But wait, what happens if things just don't go as planned? Well, this is exactly where you pull out Modifier 53 for a discontinued procedure. Say a colonoscopy can't advance all the way to the cecum because of poor prep, or maybe a severe patient safety issue pops up, like bradycardia. You just append Modifier 53. It's your key to making sure reimbursement is accurate when a procedure has to be halted midway to keep the patient safe.
And then we have the multiple polyp trap. When you're coding multiple polypectomies, your code selection is driven entirely by the technique used. Was it a snare, cold forceps, a hot biopsy? For instance, code 45385 is super specific to the snare technique. Now, if the physician removes 3 polyps using that exact same snare technique, you only report that code once. But if they use totally different techniques on separate polyps, that's when you bring in Modifier 59 or XS. That unlocks the separate payments for distinct lesions treated differently.
All right, Section 4, Intestinal Resections and Anastomosis.
When it comes to bowel resections, you have got to read those operative reports like a hawk to catch the surgical approach and the final outcome. You really need to contrast partial versus total colectomies. A partial colectomy, like 44140 for an open procedure or 44204 for a laparoscopic one, means removing a segment of the bowel with an end-to-end anastomosis. But watch the details carefully. Does the surgeon actually reconnect the bowel, or do they create a colostomy or ileostomy stoma instead? Because that one little detail completely changes the entire code family you'll be using. Section 5, Hernia Repair and Mesh Rules. Spanning codes 49491 to 49659, this is easily one of the most variable-heavy areas you're going to face on the CPC exam. To nail the correct hernia code, you have to extract 4 essential variables from the clinical scenario. Number 1, the anatomical site. Is it inguinal, femoral, umbilical, ventral, or incisional? Number 2, the patient's history. Are we looking at an initial repair or a recurrent one? Number 3, the clinical status. Is the hernia reducible, or is it incarcerated or strangulated? And finally, what's the patient's age? It's like a giant puzzle, and you literally cannot code a hernia accurately without all 4 of these pieces. Now listen up, because here is a massive exam trap regarding surgical mesh. The rule is incredibly simple, but people miss it. Laparoscopic hernia codes like 49650 for an initial inguinal repair automatically bundle the mesh insertion.
You do not report it separately. This is completely different from certain open procedures. So always verify the surgical approach before you even think about billing for mesh.
Okay, let's wrap all of this up in Section 6 with our Part 33 visual cheat sheet.
I highly recommend snapping a screenshot of this summary right now for your exam prep. Let's do a quick-fire review. For upper GI endoscopies, remember, diagnostic is always bundled into surgical. For a colonoscopy, the extent matters. It must reach the cecum. Incomplete colonoscopy, append modifier 53. For polypectomies, code strictly by technique and grab modifier 59 or excess for distinct lesions. And finally, for hernia repairs, laparoscopic codes bundle the mesh insertion.
Mastering these digestive system guidelines is a real game changer. It sets a rock-solid foundation for handling complex surgical coding logic and teaches you how to systematically break down operative notes. Next up on Decode Healthcare, we are jumping into Part 34, Urinary and Male Genital System CPT coding. We'll be breaking down cystoscopies, prostatectomies, and complex renal procedures. But think about this. If diagnostic scopes are bundled in the digestive system, do you think those same strict rules apply to the urinary system? You definitely won't want to miss finding out. Keep studying hard, and I will catch you in the next explainer.